It's right at the top of the hour. Hello, good afternoon, good morning, and good evening, depending on wherever you are. Welcome to our special COVID-19 session number 36. This is a series that we have, I think there's somebody on, just a second, let me, Fitzam, are you there? Let me just help with the controls here. Great, thank you. Welcome again to special COVID-19 session number 36. As I said, this is a series that we have dedicated to diagnostics and related matters in the COVID-19 era. Today, we have a very exciting topic. We're going to be focusing on genomic surveillance of SARS-CoV-2 in South Africa and its implications on transmission and vaccine efficacy. And to unpack this important issue, we have a distinguished Professor Tulio de Oliveira, who will unpack for us a unique set of information illustrating how pathogen genomics has become key to tracking the evolution of the virus, as well as inform our public health interventions. Professor Tulio is a director at the KwaZulu-Natal Research Innovation and Sequencing Platform, popularly known as KRISP, as well as a professor at the College of Health Sciences at the Nelson Mandela School of Medicine, University of KwaZulu-Natal, which is in Durban, South Africa. Just a few ground rules. As usual, please put your comments and questions into the chat box. We shall attend to them immediately after the presentation in the Q&A session. This will be a 1 hour long session as usual, and I invite you to sit back and relax, and let me hand over to our presenter today, Professor Tulio. Over to you.
Hello, colleagues from all the African continent. It's a great pleasure to present for you today for the ASLM, and also to some of the work that we are doing, not alone, but with many colleagues from many different places in Africa. So I really want to share with you a lot of the, I try to get a big general topic about building genomics networks in Africa. And the main thing that I'm going to mention to you is how if we work together and if you have access to high technology, sometimes we can even become leaders in the world of genomic surveillance, okay? So my name is Tulio de Oliveira, and I'm presenting here on behalf of the Network for Genomic Surveillance in South Africa, and also with some work that we are doing with the Africa CDC Pathogen Genomics Initiative. And I'm gonna mention a lot of the partners, because as you notice, a lot of time I get the credit, but in reality, it's the work of hundreds of scientists across the continent, So this presentation is not gonna be 1 hour, don't worry. It's probably gonna be like 25 minutes or so. And I'm gonna discuss a little bit the work that we did in South Africa on the Network for Genomic Surveillance in South Africa, and also this very exciting initiative of the Africa CDC together with the ASLM that we are helping to support to expand surveillance in Africa and in real time, So let's start with what we start in South Africa. So that was from beginning of the pandemic. We set up our network quite early last year. And what we did, we got a number of different genomic centers in the country who explain together always with a national lab. So For example, here in Durban, I am here in the East Coast. We work very close with the Inkosi Albert Lutuli Central Hospital. That's part of the NHLS, which provides samples and also information, metadata, and also do the science with us. So we do sequencing here in Durban, in Bloemfontein, in the center of the country, by the University of the Free State, by both Martin Nyanga and Dominic Goodels, again, together with a national lab. And then you have Stellenbosch also together with the national lab in the Tygerberg Hospital, and then the Hoortskroe Hospital in Cape Town with the NHLS and UCT, and of course the National Institute of Communicable Disease. Yeah. So what we did, we joined all these different labs and the different academic institutions in a network, which was supported by national funding by the Department of Science and Innovation of South Africa and the South African Medical Research Council. So the idea is that we would work together as a group, as a network, to try to implement quite early genomic surveillance in South Africa. So let me take for some results that was recently published a few weeks ago. Yeah. So here in South Africa, we had that's data from the first wave. Yeah, that we have. It happened around our winter here, June, July, and August. Here's the number of cases. In red is the reproductive number of the virus. And these little bars here, what they are basic the weeks that we generate genomes. Yeah. So in South Africa, we start very early. The first genome that was generated was a contact of the first case. And then as it is start, the first outbreaks will increase. And then after we come with a consistent system that would genotype almost every week. Yeah. What we learn? We learn the first thing where the virus comes from. So for example, in South Africa, I have the different colors here of the continents. Yeah. And you're going to notice that the majority of the colors there, it is from Europe. Yeah. So the majority of the virus in South Africa got introduced from Europe. And why Europe? And the answer is very simple. Around 80% of the introductions came from Europe, but coincidentally, 80% of the international air traffic outside the continent from South Africa is from Europe. Yeah. So that's how this virus moved in the first wave. It's arriving the continent by airplanes, but we think that change in the second wave, but I'm gonna get more information later. Yeah. And what we do, all these little colors here, they are represented by the black here. What it means is that very early, these introductions in South Africa, they became community transmission. That is in gray here. So more than 99% of our infections were transmitted from within South Africa. So because we are doing genomic surveillance during beginning of last year, which I have in the x-axis here, the different weeks. Yeah. In the y-axis, I have the proportion of the genomes. Yeah. And here, when I have white, it doesn't mean that I have not data. It means that I have a lot of data. But what it means that normally I have 20 or 30 different lineages here. So it's become a very busy graphic. So we are just representing white. So each time that you see white, you have dozens of lineages. Yeah. So South Africa always had dozens and dozens of lineages. And then we have the appearance of the first South African specific lineages, yeah, which you can see here in purple, in blue and green. And they got numbers in the classification, the Pango classification as B1, 54, 56, and C1. And these variants or these lineages, they were circulating most across the whole country. And they were always caused like 10, 15, 20% of the infections. In total, we estimate around 40% of the infection of that three main lineages. And the remaining 60% were dozens and dozens of lineages. Yeah? And then, as you know, things change quite a lot, especially from the middle end of November. And a lot of these lineages become almost extinct. And then we get dominated by one only lineage in the case that was quite different and that got a name of a variant, what we call the 501Y.V2. Why do we call 501Y.V2? Was the second major variant that have the 501Y mutation, which the first one, it is more widespread than this one found in South Africa or the one in the UK. And the third one is the one that was identified first in Japan and linked back to emergence in Brazil. So as you see, completely domination of one variant, and we find that in all the provinces that we have saved sample in the country. So what's the difference between these variants? The first thing, all these variants, they get quite confusing names. You have like what we have a variant name 501.v2. They have the penguin name B.1.351. And then the next strain numbering called 20G. As a community, we are trying to work together with the WHO to come with a better nomenclature. But for now, we have to live with this different nomenclature. So this variant has many more mutations, much more than the previous lineages. It has around between 24 and 30 mutations. The majority of them cause amino acid changes. And here I'm localizing gray, the ones across the genome. And then in color here, we give a focus on the spike glycoprotein. And of course, we look more in detail in the spike glycoprotein because that's probably one of the most, if not the most important protein of the virus. That's going to be the protein that's going to attach to the receptor to make the virus to enter. And this variant has multiple mutations in the spike glycoproteins. And what we find is two clusters of important mutations. The first ones are in the receptor binding domain, with the 501Y, which have been associated with increased affinity binding of the spike and fast entries and potentially fast transmission, but also these other two mutations in the receptor binding domain. And that's the one that caused a lot of attention in the last few weeks because association with decrease of neutralization of antibodies, but I'm gonna get in detail of that. It's important to note these other cluster of mutations, the non-terminal domain. And so both the receptor binding domain and the non-terminal domains, the two main protein parts of this protein that get exposed and attacked by antibodies. And we have a deletion there. And one mutation that you're going to start listening a lot in the next few days or weeks is this L18F. It's quite a big change in the amino acid, and it's also emerging both in the UK. It's also found in the variant that was discovered in Brazil, and may be associated to also either increased transmission or more neutralization. And this paper will become in Nature quite soon.
Prof, sorry to cut you short. The interpreter is asking if you can slow it down a little bit. So
yes, of course, I can slow down. Sorry, interpreters. I wouldn't like to be in the job of interpreting all these technical terms. So we are doing a great job. So one interesting thing is that the genomics network that was set up in South Africa, it became it's almost becoming a model to the world, especially to the developing countries. And that was originally the network was published in the Lancet Microbe, and in the last few weeks has received major coverage by some of the big scientific media, such as Nature, highlighting the importance of genomics network to the discovery of variants, but also what's the effect of these variants on the immune response. And that's what we focus a lot once we found the variant. This is some fantastic work from some colleague of ours that we collaborate at the National Institute of Communicable Disease. And just to ground you here, what we did as a country in December when we identified the variant, we also formed a larger network of not only genomics laboratory, but with a lot of the top scientists in South Africa focusing in immunology, virology, vaccinology, diagnostics, and clinical epidemiology to try to really understand the effects of such a variant that seems to transmit much faster, but also dominating all the infections in the country. And here, just to ground you, here's the protein of the virus, a piece of the protein of the virus. This is some experiments done in pseudovirus, that what they did is to first mutate the pseudovirus to have the 3 main mutations that are associated with the receptor binding domain. Yeah. Here, I have different antibodies that's exposed to the virus, to the pseudovirus, and then we can see the effect of these antibodies of neutralizing both the previous variant, or what we call the original variant, which it means that only have the 614G mutation at the spike, and the new variant, the 501V2. And that's a very detailed experiment that what it shows is that the previous variant neutralized it quite well, yeah, by the antibodies at high concentration, but the new variant not, and neither a mutant that only have the mutations on the receptor binding domain. And I should change here because this paper was accepted in Nature Medicine yesterday, yeah, and congratulations to colleagues, yeah. What we also did here in Durban is to take the same virus and move that to a P3 plus lab and outgrown this virus. And this is fantastic work of a PhD student called Sandile Kelly and also Alex Siegel, which we also collaborate. And what we show here now with a live virus experiment, I'm gonna take you here, that would be what would look someone that has not been infected with the first wave virus or the original virus. So what you do, you take convalescent plasma of these individuals and you expose this live virus at different concentrations, yeah? So what it means, as you increase the concentration or decrease the dilution, the original virus get neutralized. But what happened with this new variant, you see some degree of neutralization, but much, much less. And we can compare the two results, yeah. And then what Alex Siegel can do is to calculate what's the difference on the IC50, yeah. So just to simply in terms, it means that this new variant is less neutralized 6 to 200 times less than the previous variant. We're using convalescent plasma of people infected with the original variant. Yeah. And then once we have established that these variants are less neutralized by convalescent plasma, the next big question that we went to answer, what's the effect of people that have been previously vaccinated? And here it is some experiments with the SHADOX, or commonly known the Oxford AstraZeneca vaccine. And again, what we did in collaboration with Penny Moore and Alex Siegel, yeah, and the PI of that is Shabi Ahmad. You took, what we did, we took, like, in this trial was a small trial, phase 1B, phase 2A. We had like 42 infections, yeah, 23 in the placebo arm, 19 in the vaccine arm. So what we did here in KRISP, we sequenced all this virus and we had 39 of the 43 breakthrough infections were the 501YV2. Then what Penny Moore did in a pseudovirus and Alex did in a live virus is to see if you have now with plasma from vaccinated individuals, if you have less neutralization of this variant, yeah? And what you saw is very different, decrease on neutralization with the mutations in the receptor binding domain or with the full constellations of the mutation. And to be honest, more than 75% of the virus that was exposed to vaccinated plasma from individual have little neutralization, yeah. And the same results were very consistent on the live virus. The live virus is the gold standard, yeah. And that's what, not surprising, that became news all around the world, yeah. Because what it is, if you join together genomic surveillance with basic science and trialists and vaccinologists, you can quickly understand the effect of that, and end up with South Africa, rethinking about the vaccination process. Important, these results are only in mild and moderate disease. We don't know what's the effect on severe disease, which we hope and expect the vaccine still to be effective. So some of the South African vaccination plan was banned, and because these results that we have generated in South Africa. But the important news is that the whole world now is moving to try to create vaccine-proof vaccines, to try to either add an extra booster or add these variants on the vaccine to elicit faster, stronger neutralization. So just to conclude from the work in South Africa, genomic surveillance is a critical component of the epidemic response. It has been exemplified by early detection, characterization, and tracking of this new 501Y V2 variant within and outside South Africa. Now you find this variant in 32 different countries in the world and many of our neighboring countries. And we have detected a new variant with multiple mutations where you don't want the mutations to be at key sites in the spike glycoprotein, which decrease the neutralization of antibodies. I didn't show you the results, but some very clear evidence that also increase up to 50% transmission between population transmission. And this variant decreased the efficacy of certain vaccines. And now we are working around the clock with most of the vaccine manufacturers and trialists to make sure that the vaccines can be really effective against this variant. And we had good news last week. The Johnson & Johnson vaccine was 89% efficacy on preventing severe disease. And that was a trial that was run in South Africa. And we should have a lot of the results of the other vaccines, both the Pfizer and the other vaccines that have been generated, but also trying to expand the program on the AstraZeneca to see what's the effect on severe disease. Of course, that one thing that we would like, and many people that will know me will understand how passionate we are doing that as a continental scale, is to accelerate SARS-CoV-2 sequencing in Africa, not as academic exercise, but really as a public health response. And this is a fantastic program that has been put together by the Africa CDC under the directions of John Nkengasong, with Ieno Kebede and Sophonias Tesema, co-leading this program. And what they did is through a number of funders. This means the Bill and Melinda Gates Foundation, Microsoft, Illumina, and Nanopore. And we believe that we're engaging with more funders to raise substantial amount of funding to try to expand genomic surveillance in a holistic way across the continent. So how that is working. So one thing, you have a coordination, operation of the network, and the whole objective was to leverage on existing capacity to provide access to sequencing facility. So the Africa CDC PGI has worked with so many labs across all the different regions and countries to try to increase the capacity of genomic surveillance, by helping to set up national COVID-19 sequencing laboratories. Also has helped to set regional COVID-19 sequencing laboratories, but also setting up what they call specialized genomics and bioinformatics center, which at the moment 3 has been established. ACGD, that's Professor Christian Happy. Many of you will know his fantastic facilities, the South African National Bioinformatics Institute on the Bioinformatics, and KRISP in South Africa. So what's the objective of a lab such as a specialized genomics lab? The main objective is to help both regionally, but also countries to speed up access to genomic surveillance, but also to help with capacity building in a holistic approach. So what we are doing, we have signed many MTAs, and we're receiving weekly samples from a lot of our neighboring countries, especially to see what's the effect of these new variants. Yeah. So for example, that's the geographic location of these laboratories. Here I'm mapping what's called, or not me, that slide from Sofonias Tessema, the regional and the specialized Genomics and Bioinformatics Center. The regional are in red, the specialized as blue, how they are distributed between Southern Africa, Central Africa, East Africa, West Africa, and North Africa. Yeah. The idea was to mobilize resources and leverage on existing capacity. Start simple, and establish routine surveillance, support sample collection and shipment and logistics, support sequencing reagent, equipment and personnel, and support data analysis, sharing and interpretation. Yeah. So one thing that we know is that as this is being set up, genomic data production is increasing fast in Africa. We have now around 7,000 genomes distributed in 22 different countries in Africa. And another exciting thing that many of you will be part is that we have, together with the Africa CDC, contacting all the different labs, and we got support from 30 laboratories in 19 countries in Africa to pull all the data together and make a big continental data analysis. And so we just logged the data set, and we're going to be doing that with all these different labs in the next few weeks. So I'm very excited about that, because for me, it's one of the first time that I see such a large continental collaboration. Yeah. And if it's missing one or two labs, we try to contact all the labs. I think that we have another 10 that we are trying to contact. Please contact us, because we would like to do that, not only in a collaboration, but a holistic approach. All the scripts used for data analysis are going to be freely available to everyone, and it's going to follow also a discussion of the data, but also the capacity building for people that need either help on the sequencing to set up the labs or in the analysis pipeline. Yeah. So that's how the data, the public data in GISAID that all these laboratories produce in the country look like. Here is by month, here is by country. Yeah, and not surprising, South Africa has produced over 50% of the data. Again, the importance of working networks from the beginning. But we had one thing that I'm very excited to see is what's happened, for example, recently here in Rwanda, in Republic of Congo, Nigeria, and Mozambique, that we're starting seeing this continuously weekly or bi-weekly sequencing, because that's what we need. Yeah, is to continuous, and I believe that Kenya is also increasing a lot, sequencing continuously surveillance to try to understand what is happening. Yeah. So here is some data from the Instituto Nacional de Saúde from Mozambique, the INS, that show what's happened in the neighboring countries in South Africa. Yeah. So here, just to take you, is a phylogenetic tree. Everything that's inside this branch, this means from the top here, is what you call sequence from the 501Y.V2. And all these purple dots are sequence from Mozambique that have been generated in the end of December and beginning of January. So what we can learn from that? One thing that we can learn is that this variant was introduced multiple times. We can count 12 here, but more data has been produced by us in collaboration with the INS. And probably what we can easily estimate from that is hundreds, if not thousands of introductions of this variant in Mozambique. And that's the difference. We really believe that these introductions in the continent is not like the first wave that come by international air traffic, but potentially moving across the road networks within the borders. Yeah. And one thing that we worry is that what I'm going to show in the arrows is these clusters of transmissions, which show in Mozambique at least that the introductions very early as middle of December or January, it start causing localized transmission, and this variant is the classical 501v2 mutation, and either has 8 or 9 with the addition of the 18F mutation, So what's the plan of the Africa PGI that we are trying to support on accelerating SARS-CoV-2 sequencing in Africa? So we are all discussing a standardizing sampling framework tailored to the African setting. Our suggestion is a simple, lightweight surveillance that a country or a country is big, a big region, do, for example, 50 or 100 random selected samples from the facility, but you do that every week so you can understand any change, emergence of new variant. And also, when have, for example, outbreaks or see very fast transmission, that you increase the surveillance to answer a specific question, That's one of the challenge. The other challenge is how to get the market and custom issues of time availability of reagents, and I believe that the Africa CDC is working a lot of that to make that easier. Material transfer agreement and import permits, at least here in South Africa, we really got much better on that, and thank you for our health minister to really support that. So the MTAs and the import permits, so we can generate data very quick to the neighboring countries. They are coming very fast now. And what we are working is also in standardized data analysis, sharing, and reporting frameworks, Another thing that we have done, we have produced a much easier to use protocols, and they have been distributed to dozens of labs. And if anyone need any help to set up either nanopore, Illumina, or ion torrent sequencing, we are always keen to help. All our protocols are open accessible, And I'm not going to get too much in detail of that because that can get a little bit technical. But one thing that we are also doing for the 3 different platforms, it is to start to automate a lot the data processing process, and begin to get much better and much quicker. And one thing that we're going to be doing is to run a lot of capacity building for anyone that's interested to use some of these tools to analyze the data, One thing that we did in South Africa with our bioinformaticians, they are not allowed to touch the data unless it is public in the GISAID. We did that for a few reasons. One, because this means that you have like a good relational database that protected the intellectual property of especially people that sample, but quite important, all the data go to a quality data curation process and are continuously annotated with similar metadata. So what we do in our network of genomic surveillance, it is to release the data as it is assembled. What we do with some neighboring countries when we produce data for them, we let first of course the Ministry of Health to become public. Once they are public with the data, then the data would become available in the GISAID database. And we had lots of fun in the beginning, middle of the year, last year, running a lot of seminar series on COVID-19, and we're going to be restarting that with both the Institute Pasteur, the ACD, SAMBI, H3 Bionet, under the auspice of the Africa CDC and African Union. And that will be a lot to discuss scientific findings, but also as a capacity building process to help other countries to set up lab. And here's the people that do the real work in my lab. They are both the bioinformatician and the lab people. They are the real heroes. So thank you very much. It's a lot of people to thank. I'm thanking here mostly from the Network Genomic Surveillance, but also the Africa CDC and also the funders. And was very excited to see this being funded by national money. And now what we're trying to do is work with a number of partners and the Africa CDC to leverage international funding to expand the network. Thank you.
Thank you very much, Prof, for the wonderful and very rich presentation. You can see quite a lot of comments and questions coming through the chat box. and it is time for our question and answer segment. But maybe for a start, let's start lighter. Genomic surveillance may be also quite new for many of us, and also acknowledging the diversity of the audience today. So before I maybe take questions that are in the chat, maybe just a quick one for the benefit of those that are just joining now. What in simple definition, what would you define genomic surveillance and why is it important? Just quickly, then we touch the questions that are technical.
Okay, thank you. Yes, so genomic surveillance, it is basic when you use genomics. This means sequencing the genome of pathogens. That normally what they do, and you try to do that either in response to an outbreak, yeah, what they did a lot and very well in the Ebola outbreaks or in the yellow fever outbreaks that had in Angola a few years ago, or what you do that continuously. What's become more powerful, and that's why it doesn't have to be. Sometimes one doesn't have to aim at the big numbers, but sometimes just the continuous data production, you can see some change in the pathogens. Yeah. And I think that genomic surveillance is very valuable for SARS-CoV-2 as shown, but I believe that it will be valuable for many other viruses, bacteria, and parasites in Africa, because that can both increase of transmission, emergence of new disease, but also to protect diagnostics and therapies, treatments, and vaccines. Yeah.
Thank you, Prof, for breaking down that in a simple manner. So now moving on to the loads of questions that are coming through. There's a lot of, I think, sequencing that is already happening. And I would like to start with the one from Asta Tsegaye, who says, this is a very good lesson for African countries or resource-limited settings to pull resources together. And he or she says, what was the major challenge in bringing 5 institutions to work together?
It's never easy, yeah, and I like to joke that what was not, but just as a little fun joke, that sometimes the most difficult thing is to put 2 close institutes to work together, like Stellenbosch and UCT, yeah? But I'm just joking because they both join very well the network, yeah. I think that one thing that we hope that will show these networks, yeah, is that the power to do that, yeah. And in the end, if we work together, we can save a lot of resource. Yeah, that whole work that I show you in South Africa have cost so far less than $500,000, yeah, to do all that work for the year, because you are leveraging existing facilities. Yeah, we are buying reagents in bulk. We are changing protocols to each other. We are publishing very big journals, what also increased the level of the publications. But more important, yeah, we are working together with our public health response and our government. And what I find is that your government and your public health response will listen you much more if come from a big network of people together than individual groups try to communicate with him. So I found a very good thing. Of course, one need a lot of patience, yeah. And what one find at work, it is by giving a lot in the beginning. So for example, a lot of the protocols that we set up in KRISP initially, we send to all the other labs in our network, yeah. And that help a lot to build trust when they see that your objective is not to try to do yourself, but to help other labs to also participate and get capacitated on the production of data, yeah.
Thank you again, Prof. Moving on, let's move on to the element of the testing itself. And again, this is from Asta Tsegaye and also asked by Ben Stevens. They're asking about what is the criteria for selecting samples for genotyping, the type of patient population. And then Gwen also is asking how many samples are sequenced from each region and how often should this be collected? Is it just a random sample?
Yeah, so for example, here in KwaZulu-Natal, yeah, we have a fantastic laboratory of the NHLS inside because Albert Lutuli Central Hospital. And what we agree with then, that would be no selection criteria, because we wanted to make sure that we have an unbiased, what I mean no selection criteria. Every week I go collect myself around 50, 100 samples that they random selectly from clinics in the province, yeah, but with no selection of age, gender, or CT score, okay? What it means CT score, the number of viruses, because we just want to make sure that how accurate is the sequencing process, yeah? This is one manner to do, but what we do also, we complement that. We don't use all our throughput for that. That we will use, like, for example, 25% of our throughput. And then what we do, we complement that when have a big outbreak. For example, we use a lot of genomic surveillance to try to control outbreaks in hospitals, outbreaks. Yeah, in the last few weeks, we are really busy and we are prioritizing, for example, what I show you of the AstraZeneca, the breakthrough infections of vaccines. That's very important also, yeah. And so, or sometimes to reinfection. So in addition of these random selected samples, you also use your throughput to answer very important questions of that time, yeah. Or for example, if you're growing the virus in the lab, it has the virus add mutation. So you have to do that very quick. Yeah.
Thank you again, Prof. Indeed, the importance of genomic surveillance coming out clearly. Talking about this continued surveillance, and indeed, thankfully, it's catching up these new variants. I think quite a number of questions that came through around that. And implication to vaccines. But before we get to the element of vaccines, which is quite interesting of late, Pascal says, Prof, is any idea whether the increase in transmissibility will be accompanied by decrease in pathogenicity or severity as classically observed with viral infection?
Okay, so I can explain that quite well. I am a virus knowledge. I have done that for 25 years. Yeah. And one thing is that a lot of people say, oh, but if it's become more transmissible, would become less pathogenic. Yeah. But in reality, it would take probably decades to that happen. Yeah. It's not something that happened very quick. For example, HIV is still not less pathogenic after having emerged 100 years ago. Yeah. So this virus, the time of evolution is very short, only 1 year. What we see is the virus become better adapted, what it means growing in the fitness peak by being more transmissible and by starting escaping of neutralization. At the moment on the data, we don't see signal of increased pathogenicity or virulence. To be honest, we think that's exactly the same as the previous variant, but people is continuously analyzing that, because one thing that they noticed with the variant that was discovered in the UK is that they had the same pathogenicity, same of what they call case fatality ratio. But what they noticed is that the case fatality ratio was decreasing because people knew what to do better with the patient. So in the UK, they first say that was no pathogenicity different, but recently they say that probably increased 30% made patients more sick. At the moment, we don't see any signal in the data, but we also not see absolute no signal that's decreasing pathogenicity. So at the moment we assume, and our knowledge of that variant, the 501YV2 is as pathogen as the previous one.
Okay, thank you for clarifying that as well. Important as a lot of information passes through our communities. Now, talking about variants and the new vaccines coming through. Before I ask about that, there is one question, and it's not in the chat. I think it came by email. Maybe back to the basics. It's Bobe Gerard. He says, or she says, why are some vaccines not effective on certain strains? I mean, just a basic explanation.
Okay, so at the moment we are gathering more information about that. What we know is that this escape of neutralization of antibodies it has affected the effectiveness of certain vaccines. Yeah, for example, in the Novavax trial, they saw a higher efficacy in place without the variant, especially with the 484K mutation, than with the 484K mutation. The same in the AstraZeneca, the same with the slightly less the Johnson & Johnson. So we see a decrease in effectiveness, but what we also see is that the vaccines that elicit both a strong antibody and T-cell response, with the data currently is building the data, but seem to be very efficacy on development of severe disease. Yeah, that's what we see. One thing that we also see is that this virus, these different variants around the world, through a process called convergence evolution. So you may have heard that the variant that was discovered by the UK in the last few weeks start adding some of the mutations that we had in the one that we discovered in South Africa, the 484K mutation. So, and the main take-home message is that more than ever, we try to really decrease transmission and increase vaccination as fast as possible all across the world, and do not leaving a lot of poor countries behind. Otherwise, we give the chance of this virus to keep adapting. Yeah.
Okay. Thank you for that recommendation, increase vaccination as much as possible. Talking about that same lens, you mentioned earlier on that South Africa is rethinking its approach with the AstraZeneca vaccine. And I'm also picking one question interesting here from Imasiku Akokwa, who says, of course, he's referring to the Pfizer one, but he's talking about, should this be kept for a while? He's saying, how is it possible for Africa to keep the vaccine storage and transportation to maintain minus 70 degrees storage and cold requirements? Any challenges in terms of storage from your experience?
Yeah, I can throw this question back to you guys, to ASLM. Probably you have the biggest number of -8 freezers in the continent. You can explain to us.
Yeah, thank you for throwing it back. I'll pick that one up. Maybe Chewe Luo tried to sort of answer that in a way where she's saying, good to see the capacity that we have in the continent. Indeed, I think programs like the FIAs, they built a lot of capacity for storage of samples, but certainly I think we still need to move a little bit further in terms of storage capacities. And indeed, we once had a session here on this platform on biorepositories. We still need to work harder on that. So Chewe says, it's good to see that we have the capacity to do this work on the continent. How do we motivate the countries that are not listed to step up? And Pascal, along the same lens, says the PGI, the Pathogen Genomics Initiative, will it take the lead in developing standardized protocols for the continent?
Yes, exactly. The protocols are very standard, yeah, and that's why we distribute them across all the different labs that are interested on participating on that. Yeah, what we're discussing now is a two process step. Yeah, that countries that have the capacity, for example, to do 100 genomes a week with a 5 days turnaround time, for example, this has to be done quick. You don't want to discover this variant 6 months later. That they should increase the genomic surveillance themselves. They don't need any help from the specialized labs or for the regional, for example. But other countries that cannot do that they use the help of the regional and specialized labs to continue doing this genomic surveillance. And in the process, they get trained on the process, until they can, again, achieve, for example, 100 genomes with a 5 days turnaround time of receiving the sample and releasing the results. So that would be kind of a test drive to see that genomic surveillance could be effective, introduced around the different countries. And I think that's really important that we do this quite quick and quite well, because we want to make sure that we are using the most effective vaccines and diagnostics in Africa. Yeah.
Thank you for that, and we look forward to the PGI's leadership in that. I want to take this next question from Krishna Prasad from New Delhi, India. Krishna, thank you for staying up late. We appreciate your presence here. He or she says, can we identify all the probable mutations in the spike protein be characterized? If yes, can that information be used to design a new multivalent vaccine, a universal vaccine to all potential variants? Is that a possibility?
Yes. Yes, and that's exactly why it's so important to share the data in real time in database such as GISAID, because that allow both the vaccine manufacturers, but people developing vaccines to get access to all the variation, and start incorporating that. Another thing that we did very early as we started having virus stock, we also ship virus stocks to the main repositories around the world, like such as the NIH, EDCTP, in the UK, just so people could also have access to these variants, to do lab experiments and understand how better to develop vaccines that are more efficient. And I think that people took very serious the challenge, the vaccine developers, but I think that also the whole world is waking up, including to understand that we cannot leave any country behind in that, what we call like against vaccine nationalism, that even that a job of a country is not to buy 20 times more vaccines that they need, but also to help the whole world so we can get like this pandemic under control. So so new variants don't keep emerging.
Thank you again, Prof, also for the recommendations as well. And the next question is saying, can we predict, of course, it's similar to, I think you answered it partially. Can you predict next escape mutations to try and stay up ahead of the vaccine development? Are there more profitable vaccine target areas that may be prone to mutation?
So there is two important facts there, okay? The prediction of the vaccines normally is doing in pseudovirus of mutation, that you mutate every position and you keep exposing the pseudovirus to different neutralizations. So we have a good idea now in the world that which mutations would have a big effect in neutralization, But I think that one of the most important things is this continuous real-time genomic surveillance, because what's happening in South Africa, one thing that we were lucky is that we were the medical doctors that identified these variants. They saw a number of infections climbing very quick in the beginning of our summer, and then they phoned us and asked, please, we something strange here. Infections are growing far too quick, And then we mobilized the network to sample a lot of clinics around the region, And that relationship is also very important, with the clinical teams, And that you continuously do very quick the genomic surveillance. So as new variants emerge, you can identify. And one thing that we can be proud in Africa, we identify our variant much, much quicker than the UK could identify the one, So.
Thank you again, Prof. I'm quite overwhelmed with a lot of questions coming through here that we may not be able to exhaust today. So I know Prof is very busy, but we may ask to send some of the remaining questions that would have come through the chat, then we can share with the audience. Prof, you mentioned earlier on that the South African variant, if I got you right, is probably now in 32, or the new variants in 32 countries or thereabout. And I'm seeing this question from Emmanuel, who's saying, what is the geographical spread of the variant in South Africa itself? And what could be the other drivers of prevalence besides COVID?
The first thing, and apology, but I have to call your attention, is not the South African variant. Yeah, we call that the 501Y.V2. We don't even know if it was originally from South Africa. We know that we have detected in South Africa, okay? And that's why we are very careful. And it was our president itself that asked to make sure that we didn't call the South African variant, yeah? So it's not the South African variant, the 501YV2. If you want to use a different classification, you can call the B.1.351 or the 20H, yeah? So that's the first thing, yeah? And in South Africa, this variant is found everywhere, in all the provinces, and around 90% of the genomes that we produce is this variant, okay? It also has been detected in 32 different countries, yeah? The variant, the B.1.1.7, or the 501YV1, that was discovered in the UK, it has been detected in 70 countries, yeah, and in much higher prevalence than the one that have been detected in South Africa. Yeah, we believe that both of them are 50% more transmissible than the previous variants, and we really believe the reason why the variant that was discovered in the UK has been found in more countries, because London is much more connected to the international world than South Africa. Sometimes just a connection issue can make such a difference, yeah? So there is a big global effort to increase genomic surveillance, and basically every second day, this variant is discovered in other areas in the world. And why they are discovered in the other areas of the world? Because they transmit quicker. So when they're introduced, they tend to increase transmission, yeah? And because despite being limited, we still have a lot of travel across borders, either by air or by road, yeah.
Thank you again, Prof. You talked about the need to step up sequencing and also in good turnaround time. And I pick an interesting question here from Sikulile, who says, is there a role for targeted rapid bulk sequencing or ASPCR, for instance, spike only, or the costs may be the same?
Okay, so just for the record, Sikulile was a PhD student of mine, and he's the lab director of the Botswana-Harvard partnership. And of course, his questions are very good. Yeah, so yes, there is a role for simpler methodologies. Yeah. So for example, now they develop what they call melting curve assays. That's a variation from qPCR to detect the key mutations. Yeah. We also have a Sanger sequencing that sequence the spike that cover the main mutations. Yeah. And then a whole genome sequencing. Yeah. That do that. Yeah. They have different price. Yeah. But one thing that we are seeing is that as you increase the throughput, yeah, the price decreases very, very fast. Yeah.
Thanks again, Prof, for the excellent responses as well. As usual, time waits for no man, even for a king, they say. We are only left with just a minute to close, and I want to give this minute back to you, Prof, to just summarize this whole session for us. Why genomic surveillance? What are we doing? What do we really need to do to move forward?
Okay, thank you. I think that more than ever, and that's where institutions such as ASLM and the Africa CDC are so important to Africa, yeah, because we have to really join forces to understand not only this virus, but the other pathogens that we have in the continent, yeah, to be able to have a better, effective public health response. So it's great pleasure to come and present here to you. And I wish all of you a very nice Friday afternoon. Almost it's time to have a break of this conference calls and webinars and go see the family and enjoy this beautiful weather in the African continent. Thank you.
Thank you very much, Prof, for those closing remarks. Colleagues, it has been a wonderful session. I flew past very fast. And we acknowledge the loads and loads of questions that came through, acknowledging Prof's busy schedule. We will try to chase him for some of the pending questions that are here. But what we pick key important points that are coming through here is that collaboration that is really happening. The collaboration of many institutions coming through, collaboration from countries that are coming through, the data sharing that is happening. Indeed, this is what is going to see us going through this pandemic. We are all in this together, one world, one globe. Ladies and gentlemen, I'm going to share on the screen right now the details of the certificate code. If you want to go to the ASLM Academy page and download the certificate that can acknowledge your presence in the past hour, an exciting hour indeed. We'll keep on giving you these sessions coming through. Please look out for in your inboxes for the next session, session 37, which will be equally exciting. Till we meet again, have a good weekend and goodbye.